My name is Naval Daver, and I'm at the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. And today I will be talking about which patients benefit from immune checkpoint-based treatments in acute myeloid leukemia. So there has been a lot of research ongoing with different immunotherapies in treatment of patients with acute myeloid leukemia. These include PD-1, PD-L1 inhibitors, as well as bispecific antibodies, as well as CAR-Ts, and most recently macrophage antibodies such as CD47 antibodies that seem to enhance the activity of macrophages. We have done a lot of work over the last few years looking specifically at the T-cell immune checkpoints, PD-1, PD-L1, CTLA-4. What we've seen is that there are particular clinical subsets of patients that seem to benefit, especially when we think about CTLA-4. The first report was in patients who had a post-transplant acute myeloid leukemia relapse. These patients benefited significantly from CTLA-4 inhibition with ipilimumab. And in fact, in this paper that was published by the group at Dana-Farber in New England Journal, they found that 5 out of 12 patients who had post-transplant relapse AML had a complete remission with single-agent ipilimumab at a high dose of 10 milligram per kilogram. So we do think that post-transplant patients are one specific group of patients who will have a good benefit from PD-1 or CTLA-4 inhibition. In our center, we have an ongoing study that combines azacitidine with ipilimumab with nivolumab in patients who have relapsed AML. It allows all relapsed AML, but we are focusing on patients who have post-transplant relapsed AML, especially those who are 6 months or more post-transplant with good donor chimerism, and importantly, do not have significant active GVHD, because this may be a factor that could be exacerbated or worsened with the immune checkpoints. The other group of patients where we're seeing a benefit with the immune checkpoint-based treatments is patients who have extramedullary disease. So these are patients who have skin, lymph node, hepatic or other diseases, and we are seeing, especially with the combination of CTLA-4 and PD-1, there seems to be quite a good activity in the extramedullary tissues. We're trying to understand why there is such a difference in response gradients between the extramedullary tissue and the medullary tissue. At this time, it is not really clear, but analysis is ongoing using CyTOF on both extramedullary and medullary tissue. The third thing we have seen in a lot of our studies using HMA and PD-1 or HMA and CTLA-4 is that the pre-treatment bone marrow T-cell infiltration is actually a very good biomarker for response. So in patients who were treated on azacitidine and nivolumab, in 70 patients in relapsed refractory AML setting, we went back and looked at the pre-treatment baseline bone marrow T-cell infiltration. We actually found that those who went on to achieve a CR/CRi had a significantly and clinically much higher degree of T-cell infiltration, whether we look at it as CD3 or CD8, as compared to non-responders who had much lower T-cell infiltration even to start with, which indicated that there are some patients in whom the immune system is trying to mount a response towards the AML, and they already have a good amount of T-cell infiltration, and you could enhance this with the addition of T-cell activating checkpoints, whereas there are other patients who have quote-unquote immune desert, and in those patients, using T-cell enhancing strategies may not be optimal, and we may want to look at other approaches. Now, the most recent data using biomarkers or directed therapy with immune therapies is with a CD47 antibody, magrolimab. So this is an agent that enhances the activity of macrophages by blocking CD47, which is a inhibitory receptor expressed on surface of macrophages. And by blocking this inhibitory receptor, you then activate macrophages to kill tumor cells, including AML. And in some of the early data, we're seeing that there is an enrichment of response in the combination of azacitidine with magrolimab in patients who have TP53 mutated AML. So at the EHA meeting in June 2020, we presented data showing that among TP53 mutated AML, the CR/CR rate was 75%, and duration of response and median overall survival were not met at 8 months follow-up, which is much better than we have seen with almost any other treatments in older TP53 AML, not fit for intensive chemotherapy. Now, this was a small subset, and this study is being matured, but I think identifying TP53 and getting those patients either on a CD47 or on another drug called APR246 directed therapies is an important strategy. So I think these are the 3 or 4 major areas for development for immune treatment, post-transplant relapses, extramedullary disease, biomarker-driven strategies using pre-treatment bone marrow T-cell infiltration, and then potentially TP53 for CD47 antibody development, and all of these are currently in phase 2 and other ongoing trials.